ဟုတ်ကဲ့ဟုတ်ဒီနေ့ကြွလာတဲ့ဆရာဆရာမမြန်မာနိုင်ငံဆေးပညာရန်ကုန်မှာဆရာဆရာမအားလုံးမင်္ဂလာပါဆိုတော့ကျွန်တော်တို့ဒေါက်တာထက်ဝင်းဖြစ်ပါတယ်ဆိုတော့ကျွန်တော်တို့ဒီနေ့ဒီ trauma assessment session လေးကိုပေါ့နော်ဒီမြန်မာနိုင်ငံမှာဖြစ်နေတဲ့အခုလက်ရှိဖြစ်နေတဲ့ဒီငရင်တန်နဲ့ပတ်သက်တဲ့အကြောင်းအရာလေးဘယ်လိုကူညီရမလဲဆိုတော့ဥစားပေးခိုင် initiate စလုပ်ရင်းနဲ့ကျွန်တော်ဒီ UK မှာရှိတဲ့ဒေါက်တာဟီမာအောင်နဲ့ဒေါက်တာဟီမာအောင်ရဲ့ colleague နဲ့ဆက်သွယ်ပြီးတဲ့ခါကျရင်ဒီနေ့ CME webinar လေးကိုကျွန်တော်စလုပ်ခဲ့ခြင်းဖြစ်ပါတယ်ပေါ့နော်ဆိုတော့ပထမဆုံးကျွန်တော်moderator အဖြစ်ပြုလုပ်မဲ့ဒေါက်တာဟီမာအောင်နဲ့မိတ်ဆက်ပေးခြင်းပါတယ်ဒေါက်တာဟီမာအောင်ကတော့လောလောဆယ်ဒီအင်္ဂလန်နိုင်ငံ Southampton University Hospital မှာ specialist registrar လုပ်နေတဲ့ emergency specialist တယောက်ပဲဖြစ်ပါတယ်ဆိုတော့ဒေါက်တာဟီမာအောင် please
ကျေးဇူးတင်ပါတယ်ဆရာမင်္ဂလာပါရှင်ခုလိုမအားမလတ်တဲ့အချိန်ကြားရရင်ပြီးတော့ဒီ webinar လေးကိုလာရောက်တက်ပြီးတဲ့ဆရာတို့ဆရာမတို့အားလုံးကိုကျေးဇူးတင်ပါတယ်ကျမကတော့ဟီမာအောင်ပါကျမတို့ ED ထပ်ဝင်ရန်တွေ့တာတို့ပဲ emergency specialist registrar အနေနဲ့ University Hospital Southampton မှာကျမအလုပ်လုပ်နေပါတယ်အခုဒီ audience တွေထဲမှာပေါ့နော်ကျမတို့ဆရာဝန်တွေအပြင်သူနာပြုဆရာဆရာမတွေပါတယ်ကျမသိတဲ့အတွက်ကြောင့်မလို့ကျမတို့အကုန်လုံးနားလည်နိုင်အောင်လို့ overall coverage ဖြစ်အောင်လို့တော့ကျမတို့စီစဉ်ထားပါတယ်တချို့ဆရာကြီးဆရာမတွေအတွက်တီးပြီးသားတွေဖြစ်နေရင်လည်းတောင်းပန်ပါတယ်ဒီ webinar လေးမှာကျမတို့ question and answer session လေးထည့်ပေးထားပါတယ်ဒီဟာရဲ့ session ရဲ့အဆုံးမှာဆရာတို့ဆရာမတို့သိချင်တာမေးချင်တာရှိလို့ရှိရင်အဲ့ဒီ question box ထဲမှာမေးလို့ရပါတယ်ဗမာလိုရောအင်္ဂလိပ်လိုရောအဆင်ပြေသလိုဆရာတို့ဆရာမတို့အဆင်ပြေသလိုမေးထားပေးပါကျမဖတ်ပြီးတော့ဒီဒေါက်တာခရစ်စတီနာဒေးကိုကျမပြန်ပြောပြပေးပါမယ်သူကိုယ်တိုင်လည်းကြည့်လို့ရပါတယ် so today I have the great honor of introducing our esteemed speaker Dr. Christina Dale so let me introduce Dr. Christina Dale. So Dr. Christina Dale is an emergency medicine consultant at the Royal Free Hospital, London, United Kingdom. She joined the UK Med Registrar in July 2023 and was deployed to work at the UK Med Free Hospital in Gaza in March 2024. She was responsible to help set up and run the emergency department to prepare for multiple casualties and providing emergency care to the displaced population. As a junior doctor, she worked in Albania during the Kosovo War in 1990, providing healthcare to the refugees. Soon after her return, she completed the course in conflict and catastrophe medicine. Following this, she became an active member of the Faculty of Conflict and Catastrophe Medicine at the World Society of Apothecaries in the City of London, supporting doctors and nurses to train and adapt their skills for humanitarian healthcare response. She was president of the faculty for 6 years, 2017 to 2023, and acting course director 2023. Please join me in welcoming Dr. Christina Dale. Over to you, Chris.
Thank you, Hema. Mangalapa. I'm sorry, I cannot speak in Burmese, but I will speak very slowly. First, I wish to extend my deepest sympathy to you all for what is happening to you and your people at the moment. I'm sure all of you have been affected by this terrible disaster. So what I've been asked to do today is to give an introduction to how to do a trauma assessment in the context of a conflict and catastrophe. I'm aiming this talk for people who are not frequently exposed to trauma and catastrophe situations. So today, what I want to talk is a little bit about what you're probably facing at the moment, being day 8 after this terrible tragedy. I'm going to talk about the 4 S's, which you'll find out what S stands for when we get to that slide. A little bit about triage, and then how to assess patients, both adult and pediatric. There are specific medical considerations in this context, which I will elaborate a little bit more. And my final slide will have all the links for the resources that I believe you need. I will be sharing my slideshow to Dr. Hitet afterwards so that you can access these resources. So day 8, after an earthquake such as you have experienced, the needs of the population have slightly changed from the very first 2 days. I imagine you would have seen a lot of trauma, certainly in the first couple of days. That will have reduced by now, and you will be seeing more complications from that trauma a week ago. You will also be seeing both communicable and non-communicable disease. By that I mean communicable is infections such as pneumonia. Non-communicable disease will be things like heart attacks and diabetes, but also things that are not related directly to the earthquake. And of course, there will be an exacerbation of the chronic illnesses, such as asthma and diabetes. This in part will be because people will not have their normal medication, as it will be under the rubble. But also there is evidence that after such a big event, such as this earthquake, some chronic conditions are worsened and exacerbated. So the 4 S's. The first one is space. After an earthquake, there is a lot of destruction of the buildings and the infrastructure. Your hospital may be a pile of rubble now, or it may still be standing, but unsafe to use. These are when you have to consider where the safest place is for you and your patients. Sometimes, often in these situations, a lot of the healthcare is done in tents, usually in the hospital grounds. You also have to consider about water and sanitation. The electricity supply can also be very difficult. But within your setup, when you're organizing as a structure and how you're going to receive patients within the tents, you need to think about where you want the sickest, the not so sick, the walking, but you also need to consider an area for those who are expectant. Now, if you don't know what that word means in English, what I'm meaning is people who are so badly injured that you do not have the resources within you in order to be able to treat them, and that they are likely to die. But they still need dignity and pain control and care. You also need to consider a safe space for unaccompanied children. The second S is staff. You have a reduction of the staff because they've been directly affected by the earthquake, whether they have been injured or killed by the earthquake, or if they need to look after their families. You may find that you have many volunteers and maybe non-healthcare workers who want to help you. And if you think about how you're going to allocate your staff to the different areas. I would advise that you spread the expertise amongst those areas. Stuff. Stuff is the supplies that you need in order to be able to provide healthcare. In these contexts, stuff can be very difficult to get. What you have to do is use all the available equipment that you have and consider finding stuff from hospitals that have been damaged and hospitals from outside the affected area. Systems. I always think that it's good to have at least one person command and control, so that there's one person who has oversight of everything that's happening within the healthcare facility and can use this, knows about the staff and how to allocate them. It's also important, now I realize that the international effort is difficult for you, but if the WHO are near you, they will be using the cluster system and be having regular meetings. And it's important that you try to make sure that your command and control person for your facility can access those meetings to find out what is happening, both the international and the national level. And you also might need to consider how you do your shift patterns. You might need to change the way that your staff work. Triage. There is we've recently changed the way we triage. The point of triage is to make it as quick and easy as possible. So in actual fact, anybody, even a non-healthcare worker, could perform this triage, 10-second triage. And it's important for you to be able to identify the sickest people first so that they can get treatment as quickly as possible. I would recommend that you have use a tool like this in order to be able to put patients in the right areas with the right staff. At the bottom of the slide, I've got P4 for expectant. Unfortunately, after such a catastrophic event, as I said earlier, there may be people that you just do not have the resources in order to be able to treat them, as their injuries are so bad, they are unlikely to survive. This is a very difficult decision to make, and I would recommend the most senior person assists with those decisions. But what you are trying to do is save the most people you can. So I'm going to be using the WHO recommended algorithm for trauma resuscitation. This is pretty much the same approach as any other, but I thought it was a nice algorithm for you to be able to do understand that initial approach and what you can do to save lives. I would suggest you approach all your patients, regardless of what they've come with, in the same way. I do it every day when I'm at work in London. I approach all my patients thinking about their airway, their breathing, their circulation, their disability, and then I expose them. And in fact, I even write my notes in that way too. So what I've shown you here is the overall one, which is too difficult to see, and I've separated them. But at the top, it says recognize. And that is your first thing you need to do, is to recognize that you have a sick patient, and then you go on to resuscitate. Oh, hang on. Sorry. Airway. You all assess every patient you see. You're assessing their airway straight away. The best way to know that an airway is okay is if the patient is talking to you normally. If they aren't, if you are talk to them and they answer back, you know that their airway and probably their breathing is okay. But if they're not speaking, or it's limited and there's little air movement, you need to approach the patient using the jaw thrust and holding on to the C-spine. By doing the jaw thrust, because it's quite painful, they may respond to you and wake up a little bit. You look for any visible foreign objects within the airway. If you do have something like an oropharyngeal or a nasopharyngeal airway to keep it open, then you can do that. If you don't have those airways, then you get someone to keep holding the airway and you give them oxygen while you go on with the rest of the assessment. You also want to look for any possible airway injury. You look in the neck, you listen for stridor, and you sort of see if there's anything that's blocking that airway. I'm not going to talk too much about burns, but that's also there as well. One thing that has been added, which may not be so much of an issue now for you, but always when you're approaching a patient, if there's any sign of major external hemorrhage, you must make sure that a pressure is applied immediately before you go on to the assessment. Breathing. When you're looking at a patient and you see that their increased work of breathing, if they're sort of really struggling to get a breath in and out, that means that there's probably a breathing problem. If you're able to check their oxygen sats, that will tell you if the effectiveness of their breathing is good. So they're actually able to get enough oxygen into their system. Now, on the left side here, you'll see they've got the signs to look out for some of the major injury patterns that we see with breathing. So tension pneumothorax, open chest wound, flail chest, and hemothorax. Now, obviously, I realize that there's a big range of medical professionals here today. So some of the actions may be out of your scope, but it's important that you understand what needs to happen in order to be able to save this patient. Giving oxygen is on every single one. So if you've got anyone who's having any sort of breathing problems, give them oxygen. A tension pneumothorax, a needle decompression is if you've got someone who has a low blood pressure and when you listen to their chest, there's absent breath sounds on one side. And when you percuss, it's hyperresonant. And if they have distended neck veins, that means it could be a tension pneumothorax. And what I recommend you do is you get a large cannula and you put it in the mid-clavicular line, just in the second intercostal space in order to decompress. If you've not done one or seen one before, then I recommend you look it up to see how to do it. Circulation. This is where we take the pulse and blood pressure. And what is a nice quick way to check for people is their capillary refill time. I do it centrally, press on the sternum for 5 seconds, and then release and count how long it takes for the capillaries to refill and the skin changes back to the normal color. This is a good guide as you resuscitate the patient to see whether you're helping them. Again, a shocked patient will need oxygen. You give them fluids. If you have blood to give, you give them blood. If there was external bleeding that someone's applying pressure on, this is the time that you have a closer look to see if there's anything obviously bleeding. If you suspect a large limb fracture, such as the femur or the pelvis, it's very important to splint them. This can control any bleeding within these areas. Now, a lot of people have been talking about doing tourniquets. I just want to explain that tourniquets do save lives. If you've got a limb which is bleeding a lot and it looks like it may not be salvageable, then a tourniquet can be useful. However, if you are a long way from an operating theatre and for definitive care, a tourniquet can also cause harm. So a tourniquet can be useful in these situations, but what I suggest is you apply the tourniquet and then look to see if there's an obvious bleeding point and apply pressure or suture the vessel. And then you can release the tourniquet. That is if you're more than 4-6 hours away from an operating theatre. Always when you apply a tourniquet, write the time that you applied it on the limb next to the tourniquet. Disability. I'm sure getting neurosurgical care will be very difficult for you at the moment. But there are still things that you can do to optimize the patient's chances of survival when it comes to a severe brain injury. A lot of what happens with a brain injury is the secondary effects of the bleed. So if you can minimize those effects, you will be helping patients, and some of them may well survive. I would try and have them at a 40-degree angle. Make sure they have oxygen and that they're ventilating as well as they can be. Check their glucose. Make sure it's in the normal range. If you have tranexamic acid, then you can give tranexamic acid if it's been within a few hours of the injury. If you have an open skull fracture, you do all the same, but you also give IV antibiotics. Treat any convulsions as you would normally. And also what I do is I always treat pain, even if the patient can't tell me they're in pain. If I have painkillers, I give them because that can increase their blood pressure. And then you expose the body and you look for any other injuries. Try to make sure that the patient doesn't get cold. I know your climate is very hot at the moment, but an exposed patient in a tent who's critically ill is at risk of getting cold and hypothermic. Whenever you do anything to a patient, such as give oxygen or do their airway, or needle decompression, you must always go back to A and review. If the patient condition changes at all, you go back to A and B and then C, D, and E. Always go back to A and review your patient. Keep an eye on their vital signs. Now, in many of these situations, it is possible for you to stabilize the patient and then arrange for them to be transferred to another facility. I'm afraid I don't know what your individual situations are like, but if you've identified someone who needs definitive care, if you can get them to a functioning hospital, that's what you must try and do. But I must stress, if you do the simple things really well, you will save lives. In the pediatric assessment, it is very similar to the adult, but there are some other considerations you need. This is the pre-hospital assessment and intervention recommended by the Pediatric Blast Injury Manual. This is an excellent manual which goes from roadside through to aftercare for any pediatric trauma patient. I've put the link at the end of this talk, and I highly recommend you download it and have it as access, especially if you're not used to looking after children. As you can see, the algorithm is very similar. There are a couple of things that you need to think about when you're dealing with the pediatric trauma victim. They're much more prone to hypoglycemia. So always make sure that you check for that. But really the main difference is to do with the vital signs, which I've got a reference chart here for you so you can access it. Again, I would have this near you so you can always look at it to see what is normal for a child and their age, because it varies a lot. And this will be important when you're assessing a pediatric patient. We also recommend that you do the calculations for any child, because you're not going to give the same amount of drugs as you would an adult. We use the mnemonic wet flag. And in this, it demonstrates how you can calculate the weight, the energy, if a child was needing cardioversion, the ET tube sizes, both the size and also the length. Fluid resuscitation. I'd like to just highlight, I tend to always, in all pediatric resuscitations, whether trauma or not, I always start at 10 mils per kilo. And then I review. I know it says 20 mils per kilo here, but it's much better to give less than giving too much. So give 10 mils per kilo of fluids and then reassess. L is for lorazepam, so any convulsions. And there's also a diazepam one there if you don't have lorazepam. Adrenaline and glucose. So, specific medical considerations following an earthquake. So these are the things that you will be seeing more than 48 hours after an earthquake. Wounds. I'm sure that you have seen many wounds in the last few days. The majority of injuries from an earthquake are musculoskeletal injuries. Sadly, the people with the severe traumas in their chest or abdomen or head or neck have probably died either immediately or soon after the earthquake. So the people who survive usually have musculoskeletal injuries and mainly in the lower limbs. You must consider all wounds to be contaminated and infected. The emphasis on your care is to clean and debride. If you don't have sufficient supplies of IV fluids, you can use clean water for this cleaning. There should be no primary closure of wounds. What I mean is when you see a patient with an open wound, you do not close it. You clean, you debride, you dress, and then you review in 3 to 5 days. You will also need to give antibiotics. When you review a few days later, if the wound does look clean and viable and the patient has had antibiotics, you can consider a delayed primary closure. Never be tempted to close a wound in these situations, because all that will happen is it will ping open, because no infected wounds will close. They never do. So you don't be tempted. I understand that your vaccination in Myanmar is quite low. So there is a high risk of tetanus. And it's worth consider if you have access to tetanus vaccination, please give it. Fractures. Closed versus open. Closed fractures, if you can try and splint them with whatever you have accessible and try to get them in the best anatomical position, that will help with pain for the patient. And really, amazingly, bones heal very well, even if they're not really sort of look like they should on the X-ray. You may not, as I didn't in Gaza, you may not have access to X-rays. I think that there is nothing wrong if someone's got pain in their limbs and you, if they've got pain in their limbs and you have no X-ray available, then splint it, because that's going to help them, but try and get them to come back when they can in a few days' time, and then you can see how the pain is. If it was just a muscular problem, then it should have got better by then. But if it's a fracture, it will still hurt. Open fractures have a high risk of infection. Now, in normal practice, when you're not in a conflict or catastrophe situation, you would wash out the wound, give antibiotics, and get the patient to theatre as soon as possible for a thorough washout. This may not be the case for you at the moment, but what you can do is clean as best you can with as much water as you can. Then splint, making sure that there's a window so you can keep an eye on that wound. And these patients definitely need antibiotics. When you splint an acute fracture, as you all know, there will be a lot of swelling in the coming days. So always be sure to splint it with a back slab. If you have plaster of Paris, that means putting wool on the limb, then putting the plaster of Paris on one side, and then a crepe bandage wrapped on top of that. If you don't have plaster, then use whatever you can, which can be comfortable for the patient. Even if it's a bit of wood or anything, but make sure if you do use something like that, that you wrap it first with wool. wool bandaging. If there are any orthopedic surgeons in the audience, I would say the general rule is to avoid internal fixation. On the whole, it should be external fixation as far as possible. This is because of the high risk of infection. Compartment syndrome. This might be something that you have already seen. It's a clinical presentation. You do not need any tests or anything. This is purely clinical. If you have a patient who has pain out of proportion to what you expect them to have, then that should make you worried. If they're not responding to painkillers, if they have pain with passive stretching of the limb and tense swelling over that compartment, and latterly they start to get a neurovascular compromise, the feeling beyond the compartment will go, and then latterly you'll notice that the pulses and the cap refill will also start to fade. Now, this is something that's different in these situations, earthquake situations, than a normal situation. So we all know that if someone has a compartment syndrome, they should have a fasciotomy. However, certainly at this late stage, if they're presenting more than 24 hours after the compartment syndrome, a fasciotomy is contraindicated. You're going to cause more problems by doing a fasciotomy in these patients. What the recommendation is to immobilize as best you can and observe and have some slight elevation, maybe with one pillow. Crush injury. Crush syndrome is something that is seen with earthquakes. Now, this is probably a little bit far down the line, but it's possible that you are seeing people with the consequences of crush syndrome. They are often in shock. One of the biggest problems is with the breakdown of the cells that have been crushed. They get a release of potassium and so suffer from hyperkalemia and some of the consequences of that electrolyte disturbance. They're acidotic, and very late on, unfortunately, they often succumb to disseminated intravascular coagulation, DIC. As with all your patients, you should do an A, B, C, D, E approach. Check their airway. Give them oxygen. Check how they're breathing. Check for signs of shock. Are they alert or responding to verbal or pain stimulus? With these patients, if you suspect crush syndrome, you are going to give a very aggressive fluid resuscitation. You're going to want to give them at least 1 litre to 1.5 litres an hour. In children, this is the exception where I would give 20 mils per kilo per hour. you're wanting a very high urine output. If after a couple of hours of this aggressive fluid resuscitation and they're not weeing, you need to give furosemide to try and get them to diurese. You may also need to use mannitol or bicarbonate if not achieving this with fluids and furosemide. Be aware of the high potassium and give treatment as best you can for hyperkalemia. Often these patients go on to requiring dialysis and ITU care. Now, I'm not sure of your current situation. If you can transfer them, then I would. If you can't, just keep it simple, as I said earlier. Do the simple things as best you can. Try and achieve the best urine output you can and keep on top of the electrolytes. And this might get the patient out of danger. Something I often talk about when I lecture for the course of conflict catastrophe medicine is pain control. We've got to remember we can't cure everyone, we can't save everyone, but what we can do is we can comfort as many people as we can. And included in that is pain control. WHO have the pain ladder. And that means that you start with paracetamol and non-steroidals on the first instance. And then you go, as the pain goes up the ladder, you give stronger analgesia. This is the Royal College of Emergency Medicine algorithm for pain and what to give. Now, if like me, when I was in Gaza, we did not have the opioids that we needed to treat patients' pain. And this could be what you're facing as well. And it does make it difficult. What I've done on this slide is I have given you some of the doses to aim for the opioid drugs if you have access to them. But I recognize that this might not be the case. In the earthquake context, we say, I've put it here for morphine, but I would suggest for all medication, intramuscular medications, you should avoid giving them. This is because of muscle damage from the crush injury. So what else is in your toolkit when it comes to pain control? If you don't have access to the painkillers that you need, again, it's the simple things that count for the most. Remember the psychological aspect of pain. If people understand their pain, then it helps them manage it themselves. I use the example of giving birth. It's a very painful experience. But the reason why people have more than one child, they understand the pain and they know it's going to stop and they know why they have that pain, which is why women can cope with the pain associated with childbirth. Reassurance to your patients will go a long way. Regional blocks can be very useful. If you don't know how to do these blocks, I recommend that you look it up so you can use them. These are just a few that you can use, but there are many, many ways that you can, if you infiltrate 1% of lignocaine in as a block, then you can help that patient manage their pain while you apply dressings, wash the wounds, etc. Splinting, immobilization, and even traction can all help with the pain that people are suffering. I've put relaxation and hypnosis here. But again, this goes back to the psychological aspects of pain. Reassurance goes a long way. So, my top tips. What I say is always do the basic things well, and you will save lives. By sticking to the airway, breathing, circulation, disability, exposure approach, doing the most basic things, people will survive. It's a big adaptation that you're having to make at the moment. You may be outside treating patients instead of within your hospital. You have to try and adapt to your environment. And that's where the 4 S's come in. You have to make the most of what you have. If you don't have access to x-rays, blood tests, go by your clinical instinct and treat patients as you see fit. And lastly, again, everyone will have been traumatized by the events. They would have witnessed death, destruction, and we have to remember the psychological impact when something like this happens. So giving psychological support goes a very long way. These are some of the resources which I really recommend you look at. And if you can, when you have some Wi-Fi, get them downloaded onto your phones so you can easily access even if you don't have Wi-Fi. It's fine to refer to them even when you're seeing your patients. Okay, that's my talk. Thank you very much, and I'm happy to answer any questions.
Thank you, Chris. So now it's time for Q&A sessions. So far, we received 3 questions. So I won't read out the questions, but I will try to interpret. So first question is, as a member of the UK Med, because during this day we got a lot of international aids, including from the Singapore, Japan, everywhere, like kind of the Russia, China. They are at the moment on the ground, so they wanted to know: is there any plan of the UK Med to be ground?
Well, I'm actually on call for UK Med at the moment. I know that they have sent a small team to do a needs assessment. And as I said to you, Mar, the other day when we planned this, I'm sort of waiting for the email to say that they are going to be sending people. So I'm hoping that UK Med will be providing assistance.
Thank you.
It is dependent on the government, though, the UK government, though.
Yeah, thank you. They also asked me if I am also planning to camp in person, etc. So please allow me to answer in Burmese. So ကျမအနေနဲ့ကတော့လေလာဖို့အစီအစဉ်ရှိလားလို့ပြောလို့ရှိရင်လာခွင့်ရလို့ရှိရင်လာချင်ပါတယ်။ကျမတို့မှလည်းတခြား personal reason တွေကြောင့်လာခွင့်မရနေတဲ့အတွက်လာလို့မရသေးတာပါ။ So I will move on to the next question. So the next question is, how can we detect the crush syndrome for areas where we do not have a laboratory access?
So this is, I agree, this is very difficult. And certainly when I was in Gaza, it was, I'll just go back to that area. So with crush injury, it is difficult to know whether someone has the crush syndrome. But I do appreciate when you don't have laboratory facilities, it makes it more difficult. However, this is why I've been saying the ABCDE approach and treating as you find. So the acidosis, you would hope, would be treated by the fluids you're giving. That's why you're giving the fluids. The high potassium, obviously you can't be sure if they've got a high potassium, but I would suggest if they have, if they're very unwell, it would not be the wrong thing to treat hyperkalemia if you've got someone who has a crush injury. Giving insulin and dextrose together will help that high potassium. And if you give the right amount of insulin and the right amount of glucose, you will not be doing any harm to that patient. So I would, if you have no access to lab facilities, you have a patient who has been under rubble for some time, who is in shock, who is unwell, I would just give insulin and dextrose because you will not be doing harm and you're assuming they probably have a high potassium. Does that answer your question?
Yeah, I think so. Yeah. The next question is, could you please share with us point of care test diagnosis tests for common cases and infections? I think it depends on, I think they are trying to elaborate if in case when you was in the Gaza in terms of the about the recognition of infections. Is there any like kind? Yeah.
Again, I know I'm going to sound like a broken record here. It's the ABCDE approach. There will be a high incidence of infections, both from wounds, open fractures, but also, as I mentioned in the first slide, you will start seeing people with pneumonia due to exposure they're outside because they're not in buildings. So you have a high index of suspicion for infection. You go by the ABCDE approach. You check someone's airway, how they're breathing. If you hear crackles, then treat them for a pneumonia. They probably have one. Circulation, check them for shock. If they're in shock and they have a fever, then it's quite likely they have sepsis. So you need to treat them with IV fluids, and also you need to treat them with IV antibiotics. It's the level of suspicion that you have and to try and not do further harm. You will not be doing harm by giving IV fluids and IV antibiotics if you have any suspicion, because you know that there will be a high incidence of infections, especially at this stage after a major event as you had 8 days ago.
Thank you. And the next question is why you don't recommend the fasciotomy to patients with compartment syndrome who show up late. Can it resolve? I know you mentioned we have to raise the leg, and the question is, can it resolve spontaneously according to your experience?
So I have no direct clinical experience, but I have looked up in the research. Obviously, we learned a lot of lessons from previous earthquakes. And the point of not doing a fasciotomy when there's a late presentation is the complication rate and introduction of infection is a far greater risk of the benefit of fasciotomy, which is why the current guidance is to immobilize, observe, make sure there's nothing else restricting the area, the compartment, such as bandages, or get rid of those, or have them very loose, immobilize, and there are better outcomes by doing that. Obviously, if it's an acute presentation, then yes, a fasciotomy is indicated. They're even talking that even as between 8 to 24 hours, it's a bit uncertain as to whether or not a fasciotomy is beneficial. But certainly more than 24 hours, it's contraindicated from the experience of previous earthquakes.
Thank you. This is the same question we talk about why UK Med is not in the ground, etc. So I'm going to skip this question. So this is, I think the candidate is maybe in UK. So they said, how can I be a part of the UK Med to help with the medical care if I am currently in the IMT training?
So they have a process to join. You go to their website and you apply. There will be an interview, and then they have quite a lot of in-house training that you do. I think it took overall about 6 months, I think, from application to have completed all the training.
Thank you. Another question is regarding about the needed decompressions. One of the candidate asks, in the tension pneumothorax, you mentioned second intercostal space within the mid-clavicular line. They have learned in some books stating that the site could be fifth intercostal space, mid-axillary lines. So which one should we stick to?
I didn't want to overcomplicate because I don't know the audience, but you're absolutely right. The triangle of safety in the axilla is also very and has of late become also accepted and possibly better for the needle decompression. All I'm saying is that whichever one you do is fine. It's fine. Just do one of them. And so that's all I would say. But yes, you're absolutely right. But I didn't want to overcomplicate this particular talk because I wasn't aware of everybody's level.
Yeah, thank you. I think I'm going to take this question for myself. they ask, is there any further sessions that cover mental and psychological problems and their management? It is one of the most important and needed problems during the current crisis. ဟုတ်ကျမတို့အဲ့ဒီအခုဒီ session ပြီးသွားလို့ရှိရင်ဆရာတို့ဆရာမတို့လိုအပ်တဲ့ session ကိုထပ်ပြီးတော့လုပ်ပေးဖို့ကျမအစီအစဉ်ရှိပါတယ်ဒီဒေါက်တာထက်ဝေရန်တို့ကနေတဆင့်ကျမတို့ထပ်ပြီးတော့ဒီဘက်ကpsychological team member တွေနဲ့လည်းထပ်လုပ်ပေးဖို့အစီအစဉ်ရှိပါတယ်အဲ့ဒါတော့ဆရာတို့ဆရာမတို့ရဲ့လိုအပ်ပုံမှာမူတည်ပြီးတော့ထပ်လုပ်ပေးဖို့အစီအစဉ်ရှိပါတယ်ရှင်So another question is, I wanted to know in what situations can we use tourniquet or close the womb?
Say again, sorry, in what situations?
So they wanted to know in what situation they can use the tourniquet or close the womb, sorry.
Oh, use glue or close the womb. Okay, so I think it's really, I mean, as I said in the slide, I think it's really important. The emphasis is on cleaning and debriding any dead flesh, and putting a dressing on. The wound will heal eventually. But it will be secondary intention. But if you've been cleaning and you've put the patient on antibiotics and you've debrided all the dead tissue, and then after a few days you review the wound and it's looking nice and pink and viable, then you can try and close that wound.
Mm-hmm.
All I'm saying is I've seen plenty of wounds which were contaminated and they were closed, and as soon as the sutures were removed they just go bing. They don't close. They just don't close. So it's better, as you know, with primary closure, we're getting the edges together and then and things will heal underneath. With secondary intention, it heals from the bottom of the wound up to the top. It will heal, and the main thing is you haven't closed in the bugs. And that's the thing about primary closure. But there are situations where a delayed primary closure, if the patient's been taking antibiotics, the wound has been cleaned and debrided, and then is reviewed a few days down the line and it's looking good, then yes, sure, give it a go. And if it's infected, it won't close.
Yeah, thank you. I think that answered the question. Another question is, as you experience in Gaza, what is the most commonly used antibiotic for emergency wounded patients, and what kind of emergency drugs are most commonly used?
Oh,
I think that
antibiotics were a nightmare in Gaza, and I just used whatever I could. It depends what you've got available.
Yeah, I think so. It depends on also the common prevalence, because I don't think it can apply what you have used in Gaza in Myanmar, because the common pathogens are quite different in each country.
Yeah.
So
I don't know. I mean, Gaza had absolutely no antibiotic management. And as you all know, because of resistance of antibiotics, a lot of countries are trying to control what antibiotics we give for what infection. In Gaza, that didn't really exist. We had very little in the way of medication, full stop. So yeah, I gave as broad a spectrum as I
Yeah.
could find, basically.
Yeah, I think we have to, whatever we have available, we have to use first broad spectrum antibiotic and then reassess. Because
Yeah.
in our country also we do have a lot of the antibiotic resistant issue. But I think in that context, patient reassessment and then your wound reassessment is more, important. And then we have to make a clinical decision whether we should change the antibiotic or not, I think.
Mm.
Another question is, what analgesic should be used as a painkiller as an alternative? We also have a lot of struggle to get morphine, ketamine, codeine in Myanmar as well. So what would be your advice for that?
This is so difficult because if you don't have access to these medications, it's really difficult. I I really that was one of the worst things in Gaza was that um, the pain control was it was just oral paracetamol and oral ibuprofen. We didn't even have intravenous. So it's very difficult, and that's why the only thing you can do. I mean, the one thing is that you do have most of the trauma you will be seeing, I imagine, will be musculoskeletal trauma. Um, and you can do things by, I mean, immobilizing the limb helps enormously. So and it's the psychological. I mean, you don't have much basically. You don't have
Yeah.
much. And but you just have to. The reason why I put it in the lecture was because if you did get it or have it, then you knew how to use it. But if you don't have it, there's not really much more you can do than splinting. Do you have lignocaine access? Do they have
Yeah,
lignocaine?
I think it depends on where they are.
Right. Okay. So, there are all sorts of, ring blocks for fingers. If you've got upper leg injuries, fascio-iliac block. Do you know how to do that? It's very.
I, I don't think we very frequently use the fascia iliaca block back in the country. But regarding about this procedure, I think we can land, and we do have a Myanmar clinic guideline. This is we created with a lot of the expertise from Indonesia. So there's a website. I just wanted to mention about this, including the fascia iliaca block, which is very useful in terms of the pain management.
And very easy, and very
Yeah,
easy.
yeah. So when I was back in the country, we did not frequently use it, but I think which is very useful in terms of the pain control. So those procedure, what you have mentioned previously, like kind of the needed decompression, etc., etc. So we created this Myanmar clinic. I already pop up in the chat, which is valid and which is also provided like kind of with help from the international expertise, including and adjusted with the local expertise as well. So this website, in there we have a procedures case session. So for the audience, I do recommend you can review and then you can learn from that website if in case there's any like kind of procedure you need to brush up and then you need to.
Oh, good.
Yeah.
Hey, Mark, and I'm assuming it's all on anatomical
Yeah.
ways, not
Yeah.
ultrasound. Good.
Yeah.
Yeah,
Yeah.
because
Yeah.
people might not have ultrasound. So,
Yeah. Yeah.
and the fascia iliac block is really easy.
Yeah. So the next question is, I think I'm going to take this question. So regarding about the insulin and dextro treatment for the hyperkalemia, they wanted to know the dose. So we can share the kind of the hyperkalemia treatment guidelines with you. So we will share it, I promise.
Yeah.
How can I, the next question, how can I be part of a Myanmar clinical guidance website contributors? ပတ်သက်ပြီးတော့ကျမမြန်မာ clinical guidance website လုပ်တဲ့လူတွေကိုပြန်မေးကြည့်ပေးပါမယ်ကျမတို့ previous အရင်တော့စာတင်တာတွေမှာပါပြီးဒါတွေကို reference လုပ်ခဲ့တာမလို့ဒီ website ရှိတယ်ဒီ website ထဲမှာ procedure တွေပါတယ်ကျမတို့ participant အနေနဲ့ပါခဲ့တာဒီ session တွေမှာပါခဲ့တာပဲရှိတာဆိုတော့ပြန်မေးပြီးပြောပေးပါမယ်နော် so what the next question is So what would be the coordination of the public health activities such as the disease control and surveillance in current earthquakes given the limited and complex context and issue? I think I'm going to take this question as well. Or
okay.
Do you want?
No, fine.
So tomorrow ကျတော့အခု Christo ကျမတို့ကကျတော့ clinician တွေလို့ဖြစ်နေရ public health နဲ့ပတ်သက်တဲ့ကိစ္စ public health overall view ကိုမကျွမ်းကျင်ကြဘူးပေါ့နော်အဲ့ကိစ္စနဲ့ပတ်သက်ပြီးတော့ဒါခက်ခဲတယ်လို့ပြောရမယ်ထင်တယ်ပြီးတော့ဟိုကျမသိတဲ့လောက်ကတချို့ public health ပေါ့နော်ဒီ UK မှာလည်းရှိနေကျမသိတဲ့အသီးတွေထဲမှာလည်း public health နဲ့ပတ်သက်ပြီးတော့ MMOC ဆိုပြီးတော့ကျမတို့ဟိုလေteam တစ်ခုရှိတယ်သူတို့ကအခု public health နဲ့ပတ်သက်တဲ့ coverage တွေကိုဟို clinical teaching session လိုမျိုးလေးပေးဖို့ရှိတယ်ပေါ့နော်အဲ့ဒါကိုပဲကျွန်မ reference လုပ်ပြရစီ okay so the another question is realistically speaking the importance of kicking the rapid and effective triage system in the proximity of care is paramount so based on your ground level of experience what would you recommend as something a bit touching on the triage system to be at the most effective in the crisis context?
Sorry, I'm not sure I understand. So, what?
So they wanted to. What they said is regarding about the triage.
Yeah.
So the effective triage system, they thought is paramount. It's like kind of complex. So they wanted to know a bit of what is the effective and simple and quickest ways regarding about the triage system to be effective in the crisis situation.
So yeah, I mean that's why I would recommend using the 10-second triage because it is probably the simplest way of identifying the sickest patients. Hang on, if you let's just see if I can get to it. Because here we go. So you want the simplest and quickest way to triage patients. And so anyone who's walking, you know that their airway is okay, they're breathing, they must have enough of a blood pressure to be able to be upright and walking, and they're alert. So from an A, B, C, D point of view, they can be allocated to P3. Now, that's not to say that one of the, some of those patients aren't seriously ill. So you don't tuck them away in the middle of nowhere. You need to have someone medical reassessing them and doing a primary survey, which is the A, B, C, D, to see if they can identify anything that would mean they deteriorate later. Okay? So then if they're not walking, if they have severe bleeding, so catastrophic hemorrhage, then they are going to be people who are critically ill, the P1s, and they're the emergencies. So you apply pressure to where they're bleeding from, and then you put them into your resuscitation area. If they haven't got catastrophic hemorrhage, but they're talking to you, you know that A is all right. You know that B is all right. You know that D is all right. So what you need to then do is check for any penetrating injury, which in this context is unlikely, I know, but in a conflict context, that is important. If they have a penetrating injury in their torso or back, they are also an emergency. But if they don't have severe bleeding, they're talking to you, but they're not walking, they need urgent assessment. They're P2. So if they don't have severe bleeding, if they're not walking, they don't have severe bleeding, they're not talking to you, that's when you want to see if they're breathing. If they are breathing, then they're an emergency. If they are breathing, even with, you might have to do simple maneuvers. However, if they're not breathing, it will depend on what resources you have, because clearly these patients are in cardiac arrest or dead. So, so depending on what resources you have will depend what you do at that point.
Thank you, Chris. I just wanted to add on some, because today we did not cover for the mass casualty, like kind of the preparedness, because the triage is also linked with how we prepare when we are going to the field, and how we are linking to which hospital, and especially like kind of the local field, what resources we available. So let me explain a little bit more about which in terms of the applicability, like kind of. So ကျမတို့ဆရာတို့ကကြတော့ field ကိုသွားတော့မယ်ဆိုရင်ဒါကြတော့အခုကျမတို့က mass casualty လိုမျိုးလူနာအများကြီးဖြစ်နေတာပေါ့နော်ကိုထူကိုထစနစ်နဲ့ကျမတို့ဆရာမတို့ကteam leader အနေနဲ့သွားတော့မယ်ဆိုရင်ဒီ triage system လေးကတကယ်တော့သူကမြန်တော့မြန်တယ်ဒါပေမဲ့အဲ့ဒီ triage system ရဲ့အနောက်မှာတော့ကျမတို့က backup တွေရှိရမှာပေါ့ခုနကပြောသလိုမျိုးစကားပြောနိုင်တဲ့လမ်းလျှောက်နိုင်တဲ့လူတွေအကုန်လုံးကိုကျမတို့ P3 လို့သတ်မှတ်လိုက်တယ်အဲ့လူတွေကိုမှနောက် A to E assessment ကိုဆရာမတို့ထဲကနောက်ဆရာဝန်ဆရာမတွေကဆက်လုပ်မှာပေါ့ခုနက sick ဖြစ်နေတဲ့ patient ကိုကျတော့ကျမတို့ကဘယ်ဆေးရုံကိုပို့ရမှာလဲဆိုတော့ဆရာတို့ဒီ field ကိုသွားတဲ့လူတွေကချက်ချင်းကြီးဆရာတို့ကဒီလူတွေကို sick ဖြစ်တဲ့ patient ကိုဥမာအားဖြင့်chest drain တို့ဘာလို့လုပ်တိုင်တာလောက်တော့ကျမတို့လုပ်လို့ရမယ်ကျန်တဲ့ further treatment ကကျတော့ဆေးရုံလိုနေရာမျိုးမှာပဲသွားလေးလို့လုပ်လို့ရမှာပေါ့နော်နောက်တစ်ခုကဒီ P1 နဲ့ P2 ကိုပေါ့နောက်တစ်ခုကတော့ P4 ပေါ့အဲ့တော့ပြောချင်တာဒီ triage system ကတော့ကျမတို့ရောက်သွားပြီး field ထဲမှာဆိုလို့ရှိရင် triage လုပ်တဲ့လူတွေအတွက်ကမြန်တယ်နည်းနည်းတော့ရှုပ်တယ်ဒါပေမဲ့ဒီ flow chart တိုင်းသွားမယ်ဆိုရင်အဲ့ဒီဟာရဲ့နောက်ကွယ်အဓိကတော့ကျမတို့ကလူနာများကယ်နိုင်သမျှကယ်လို့ရအောင်လုပ်ပေးတဲ့သဘောပေါ့ဒီနေရာမှာဒီ triage နဲ့ကျမတို့က definitive diagnosis တွေပါတော့ရမှာမဟုတ်ဘူးပေါ့နော်Okay, so I think I'm going to move on to the next question. Is it because of reperfusion syndrome in patient with the compartment syndrome who showed up late?
Sorry, say again?
So the reason why we did not do the, I think, fasciotomy is is it because of reperfusion syndrome in patient with the compartment syndrome who showed up late?
Yeah, so as I'm sure you are very aware, patients can be under the rubble for some time, and so you know the compartment syndrome can, and also they struggle to get access to healthcare. So, and, you know, just getting access, because if you've broken your tibia, and you're in a rural location, it might be very difficult. And also all the roads are disrupted, and there's so much infrastructure that's disrupted that sometimes getting to healthcare is very difficult for victims of an earthquake. So there are a lot of delays, which is why, you know, sadly, there are three peaks of mortality following an earthquake. There's the immediate deaths. There's the ones after a few hours. So those are the ones who probably have severe head, chest, abdominal injuries. And then latterly, it's there's a third peak a few you know, days afterwards, which is the complications of that trauma. So, and part of the reason is because of the delay in access to healthcare. And therefore, you know, it's unusual in normal circumstances to have someone present late with a compartment syndrome. And that's why we're also used to doing the fasciotomies, because the pain is so great, people get to healthcare. But in an earthquake or conflict situation, sometimes it's really difficult for patients to get access to healthcare. So, so they do present much later than they would in normal circumstances, and that's the point, and that's why people have looked at this and realized that the risks of a fasciotomy in a late presentation are greater than the benefits.
Thank you. The last question is regarding about sharing the slides. So maybe they missed initial part. So I think that is all for the Q&A sessions. So definitely, tomorrow share the PowerPoint slide deal. The Dr. Terry and the one it sent. Registrar လုပ်ထားတဲ့ email တွေအကုန်လုံးဒီ share slide လုပ်ပေးမှာပါကျွန်မချက်ပေါက်ထဲမှာလည်းဒီခုနမြန်မာ clinical guidance.com အကြောင်းကိုဒီမှာထည့်ထားပေးပါတယ်အဲ့မှာ procedural case တွေကိုလိုက်ပြီးတော့ဆရာတို့ဆရာမကိုကြည့်လို့ရပါတယ်so my sincere thanks to Dr. Chris sharing for your very thoughtful and very comprehensive presentation and sharing the time with usဆရာတို့လာတက်ပေးတဲ့ဆရာတို့ဆရာမတွေအကုန်လုံးကိုလည်းကျေးဇူးတင်ပါတယ်ကျမစိတ်ထင်တော့ကျမတို့ဒီမှာပဲဒီ section လေးကိုရပ်နားလိုက်ပါမယ်နောက်ထပ်အခုလောလောဆယ်အထိတော့ဆရာတို့ပြောတဲ့ထက်မှာဟို psychological perspective ကနေပြီးတော့ထပ်ပြီးတော့ဟိုလုပ်ဖို့ပေါ့နော် so အဲ့ဒါဟုတ်ပြီso အဲ့ဒီဟာနဲ့ပတ်သက်ပြီးတော့ကျမရဲ့ specialty အောက်မှာတော့မဟုတ်ဘူးဒါပေမဲ့ကျမစူးစမ်းပြီးတော့စီစဉ်ပေးပါမယ်ထပ်ပြီးတော့အကယ်၍တခြား clinical topic တွေပြောပေးစေချင်တာအသုံးကျမယ်အသုံးတည့်မယ်ထင်တာရှိလို့ရှိရင်ကျမတို့ဒီချက်ပေါက်ပဲဖြစ်ဖြစ် Q&A ထဲမှာဖြစ်ဖြစ်ထည့်ထားပေးပါကျမတို့စူးစမ်းပြီးတော့ session တွေကိုစီစဉ်ပေးပါမယ်ရှင်
ဟုတ်ဟိုဟိမာလည်းကျေးဇူးပါဆရာဆရာဟိုလာတက်ပေးတဲ့ဆရာဆရာမရဲ့အကုန်လုံးလည်းကျေးဇူးပါဆရာဆရာမတို့အနေနဲ့တခြား topic တွေဟိုစီစဉ်စေချင်တယ်ဆိုရင်ကျွန်တော်တို့ဒီမှာ feedback form လေးတစ်ခုပေါ့နော် chat box မှာလည်းချထားပါတယ်နောက်ဆရာမတို့ register လုပ်ထားတဲ့ email တွေကိုလည်းကျွန်တော်တို့ဒီ feedback form လေးပို့ရတော့ဖြစ်ပါတယ်နောက်ပြီးတော့ဆရာမတို့ဒီ register လုပ်ထားတဲ့ email ကနေတစ်ဆင့်နဲ့ဒီ recording video ရဲ့ဒီဆရာမဒီ Dr. Chris ပြောသွားတဲ့ slide တွေကိုလည်းကျွန်တော်တို့ share ပေးသွားပါမယ်အဲ့ feedback form မှာလည်းဆရာမတို့ထပ်ပြီးတဲ့ခါကျရင်စီစဉ်ပေးစေချင်တဲ့ဒီ disaster နဲ့ပတ်သက်တဲ့ဒီ topic တွေကိုလည်းဆရာမတို့ထပ်ပြီးတဲ့ခါကျရင် request လုပ်ထားလို့ရပါတယ်ဟုတ်အားလုံးကျေးဇူးအများကြီးတင်ပါတယ်ဟိုဟိမောင်လည်းကျေးဇူးတင်ပါတယ် Chris ကိုလည်းကျေးဇူးအများကြီးတင်ပါတယ် thank you Chris for the very thoughtful season yeah
You're welcome, and I will send you the slides now.
Yeah.
And if anybody wants to ask any questions, maybe go through you or Dr. Hetet. I really don't mind. if I can help in any way.
Thank you so much,
Thanks. Thanks.
Dr. Christina. Yes, thank you
Bye.
so much. So see you again.
See you. Bye.
Bye.